I know. You were probably thanking me so much for including all of this information in two parts. Well, please, please. The pleasure is all mine. Let's go ahead and begin talking about the second half of diabetes. If there is one area I could challenge you to sort of become an expert in, it would be here. Not many nurses can really dialogue with patients well about what kind of diet changes they need to have. But the graduate from University of West Florida, you're going to be able to have a informed conversation with your patient and motivate them to change their behaviors. Amen? Right. Okay. One of the things we need to do is consult a registered dietitian. Now, if one comes and has a consultation with a patient, our job as nurses is to reinforce what they said. And I'll kind of give you some general suggestions of what a registered dietitian is going to teach them. They are going to try to incorporate food of their cultural background. If a person, say, prefers tortillas and beans and rice, and that's the main staple of their meal, we should not go in there and say, okay, you cannot have these anymore. We're going to try to find a bunch of different options that could be substituted in and help that patient feel like it's a substitute that's going to satisfy their cultural palate. Because if not, we're going to have non-compliance issues, and we all know where that goes. So please make sure to reinforce and to consider somebody's cultural background. Double check their financial status. Maybe a mainstay of their food and their diet is actually highly processed foods, but there are some good options that come in canned food. So encourage a person to share with you their financial troubles and ask them what are the chances and probabilities that they could consider other types of diets and lifestyles. Lifestyle meaning less drive-through and more planned meals. That would definitely be helpful. Let's ask our patient to keep a food diary. This is very important, especially if we're trying to set goals for weight management, if we're trying to set goals for lipid and glucose profiles. Having that hard data lets us make informed decisions. Otherwise, it's a bunch of guesses. It is really important for your person to have a consistent and timely intake of food. This is actually going to help control their blood sugar even better. And this is honestly something a non-diabetic should go by too. And what I mean by that is we're not doing ourselves very good by going throughout the majority of the day not eating, and then we blast our body with tons of food. This is very detrimental to the diabetic patient, but wouldn't hurt if we would actually take a note or two on this on this topic. I know intermittent fasting is a big deal right now, but I'm not a fan. Let's just say that. And this would not be good for the diabetic patient. FYI, maybe even dangerous. Do include in your conversation the person who preps the meals. Oftentimes, just as an example, the husband, the patient, he is in there getting all this education, and you know what? He's not the one who shops for food. He's not the one who cooks the food. Find the spouse. That's the one you need to really get to be the stakeholder in making sure the food that is available to that person is of good quality and appropriate, I should say. We need to avoid the whites. The white simple carbs. Those are dangerous, very, very dangerous. Ones that I'm thinking of are white rice, white pasta, white bread, and white potatoes. I know I just completely ruined the American diet by saying all that. So avoid the white simple carbs, white rice, white pasta, white bread, and white potatoes. We need to avoid sugar sweetened beverages, those or anything that really contains high fructose corn syrup. I see these advertisements that high fructose corn syrup is actually fine and it's good. It's really not. It's too processed. Our diabetic patient does not benefit from this. They can have diet beverages, that is fine, But that's a whole different topic if you want to talk about those artificial sweeteners. Some people believe it causes brain cancer. I don't know. I'm sort of for it and against it. All right, focus. When it comes to fat consumption, we need to eat the monosaturated fats. Some good examples are avocados, nuts, maybe almonds or walnuts, seeds, sunflower seeds, olives. Oh, I always pick those off the pizza. Here you go, honey. It's because I love you, and really it's because I can't stand the taste of them. All right, olives and dark chocolate. I know, dark chocolate. Yes, I give you a green light for dark chocolate. Alcohol consumption. This one is tricky. Patients are allowed to consume in moderation alcohol. However, we want to make sure that they know to eat a small meal before ingesting alcohol. I actually had a student who was at a spring break party down in Panama City, and she was hanging out with her friends, and here was this guy passed out on the couch. And it was a hot time. It was, March, and he was laying on the couch sweating, and she didn't think much of it until he began whispering something. And she asked, somebody who knew him, what's going on, and they felt, oh, well, he just, he drank way too much. Excuse me. Well, she went ahead and decided to get a little closer, and he was trying to tell her sugar. He was actually whispering, sugar, sugar. And she was like, what in the world? Okay. The only thing she had, they actually didn't have any like mixed drinks like Coke or anything, but she had a granola bar in her purse, and she tried to put it in his mouth, and he couldn't swallow it. He was that out. So she told me that she chewed it up to like really small bites and then put it in his mouth and aroused him enough to, at least tried to, get him to swallow it. He was able to swallow it, like a little birdie. He was able to swallow it, and he slowly came to, and he had actually not shared with his friends he was a diabetic. And that's actually very important. If somebody is going to be, with that diagnosis, they need to share with others. In the event there's the hypoglycemic episode, somebody can come to your rescue. Because if not, you're a goner. Right. All right. Alcohol in moderation. If not, it causes hypoglycemia. Well, wait, I heard that alcohol can increase somebody's sugar. Yes, if it is a very mixed drink. However, you can look up, if you want, articles on the impact of alcohol on the liver and somebody's glucose regulation. It may spike it, but in the end, it's going to drop down and cause hypoglycemia if somebody does not have food inside them. Okay, I'm done preaching. Carb counting. With our patients who are doing a very good job of controlling their carbohydrates, and they have to administer insulin based on how many carbohydrates that they're going to eat, they are going to go on the average calculation of 15 grams of carbs equals 1 unit of insulin. So a patient will actually sort of measure out. They'll have to read labels. This takes a lot of time and a lot of careful calculation. But they will be able to estimate what is 15 grams of carbs in a substance, and for that they will figure out how much insulin they're going to give themselves. So quick, I have 45 grams of carbs from my carrots and my strawberries and my salad with chicken on it. How many units of insulin am I going to administer? Exactly 3 units of insulin. Okay. We're going to make sure to inform patients to monitor their blood sugar just before the meal, eat the meal, and then 2 hours after the meal. This is actually going to let the doctor know if this ratio is working, especially if the person is being consistent. It's a little bit of a holistic picture of our patient. We really need to try to keep their sugar less than 180 after a meal. After 140 would be great, actually, but it kind of depends on the patient. There is such a thing as hyperinsulinemia. I know, hyperinsulinemia. I've actually had a couple of diabetic students who giggled when they heard this, and I said, well, what does that mean to you? Are you giggling? And they said, well, and these are type 1 diabetics, they will actually eat a donut and they feel okay with it because they'll just give themselves extra insulin. Now, it's not going to hurt you one time. However, if a person continues to do this pattern, oh, I'll just eat this cake and give myself a whole bunch of insulin, and then that same day do another dosing like that, it's actually going to lead to some weight gain. So we need to focus on calorie restriction rather than increasing our insulin for meals. Focus on restricting calories rather than just upping somebody's insulin for meals. Okay, so we know our diabetics need to exercise because a sedentary lifestyle can actually worsen somebody's diabetes and all of the different complications. So what do they need to know about exercise? Well, the first thing they need to know is before they exercise, they actually need to reduce their insulin dose. This is something where the doctor will tell them to take a little bit less or no insulin just before exercising. Reason being, throughout their exercise, their skeletal muscles are actually going to be using that sugar, and if we have a lot of insulin in their system, we are going to cause them to go hypoglycemic. For unplanned exercise, maybe a father who is diabetic wants to go and run around with his kids because they requested him to, put the plate down and go play. I guess he would need to, for unplanned exercise, consume about 10 to 15 grams of carbohydrate, maybe per hour for moderate intensity. So little snack and go play. The patient's sugar should be greater than 80 before they exercise. Ideally, we would like it to be about 100. If it climbs above 250, the person needs to get their sugar back down and then they can exercise. So sugar must be between 80 and 250, ideally 100. Patients need to double check their ketones and make sure they are absent. If we are going to exercise in the event a patient has ketones floating in their bloodstream that's being peed out, being urinated out, we are just asking for a good episode of ketoacidosis and a person's actually going to get ill. So they are not supposed to exercise if ketones are present in their urine. I will say if a diabetic is losing weight, they may already have ketones in their urine. This needs to be very closely monitored, and suggestions should come from a dietitian and from a physician about how much is too much ketones. Exercise under a doctor's discretion. Stay hydrated. It's very important that a person is drinking while they are exercising. They do not need to exercise in extreme weather or near the peak of their insulin or even 1 hour of injection. And this is due to the hypoglycemia. They're increasing the risk for that. Those with diabetic retinopathy should avoid Valsalva maneuver. Any kind of workout where somebody needs to do the Valsalva maneuver, need to be avoided because we can actually cause vitreous hemorrhage or retinal detachment in the eye. What? Well, how do you do that if you're exercising? I mean, I don't even know. Oh, where'd it go? There it is. This is an activity that is actually going to induce a Valsalva maneuver. By definition, if you need one, Valsalva maneuver is in which a person tries to exhale forcibly with a closed glottis. So they basically hold their epiglottis shut so that no air goes out through the nose or the mouth. What they are recommended to do is if they're going to do some activities like this, they need to breathe through the activity, breathe through the motions, because we are going to pop a blood vessel in the eye, and that's not good. I actually love this picture because there's a skinny guy on the left, and he's like, I could totally have lifted that set. Move over, man. Okay. Proper footwear. It is very important to reduce injury since diabetics are at risk for peripheral neuropathy. They need to inspect their feet every single day. Proper footwear includes shoes that are a little bit larger and they don't create wear points. So supportive thick socks are good as well. Exercise. I love old people. The recommendation is that diabetic patients exercise about 150 minutes a week. Yep. They need to engage in moderate intensity exercise, and what I mean by that is roughly they need to get within 50 to 70% of their maximum heart rate. And there's little charts that you can figure that out using your, I believe it's gender, height, and weight. We really want to encourage our patients not to be sedentary and to avoid going 2 days in a row without aerobic exercise. Move it or lose it, Grandma. Ooh, hospitalization. A lot of the patients we are going to see in the hospital have diabetes, so this is a very important slide to pay attention to. Their sugar is probably going to be elevated, and one thing we are going to have to work hard to control. It's going to rise for a multitude of reasons. One of the reasons is corticosteroids. The one drug that comes to mind is prednisone or deltazone. This is going to increase a patient's blood sugar, and we'll have to manage it with some insulin administration. We oftentimes are going to be holding our person's anti-diabetic medications. Maybe it's metformin or glucophage because they're having a CT contrast, or maybe the person has a bowel obstruction and they're NPO, but their diabetic medication is not given to them as if they were out of the hospital, so we're going to experience hyperglycemia. Just the very act of having decreased physical activity, that can raise a person's blood sugar. So if you're wondering, why is my patient's sugar so high? Well, they're sitting around, or they're on a ventilator, not moving. Illness in itself can actually cause the body to release stress hormones. It's thinking it needs to cure itself, and unfortunately that means the sugar is going to be more elevated. Stress raises sugar, and tube feedings. If we see that a person's sugar is consistently high and the body is not adjusting well, we actually may have to change formulas. A lot of times we'll give patients Glucerna or sugar-free formulas. That's what you see in the picture there. What else causes sugar spikes? Anesthesia and surgery. So what are we going to do if our patient is NPO? If our patient is NPO, we need to make sure that we hold any rapid or short-acting insulins. A lot of times we might still give NPH, and we might still give Lantus or Levemir. Lantus is also known as insulin glargine, but we definitely want to hold the rapid or the short-acting unless the person's sugar is really high and it's indicated. We need to hold anything that ends with Tide. Of course, I can't think of an example right now, but there is in the first PowerPoint, there was a bunch of medications we talked about that, hold if NPO or give with meals. If you skip the meal, skip the med. I do believe that they end with Tide. They are usually amylins or incretin mimetics. They act sort of just like insulin. Okay, in addition to giving the insulin glargine that I mentioned, we might not give the same dose that a person could get at home if they were eating. We may actually not give it at all, or we'll give a reduced dose. I know a lot of times if I'm prepping my patient for surgery and they get a nighttime dose of insulin, I will look at their chart. There's usually a protocol and it says reduce patient's Lantus by 40% if NPO for surgery. And then I'll have to give a low dose. I'll do some math and give a low dose and make a note of why I'm giving a low dose. They're NPO for the protocol. Okay, I think I skipped surgery. No, I didn't skip it. All right, surgery. Oh, all my CRNAs and my people who want to work in surgical type units or acute care settings, please listen up. Surgery exacerbates diabetes and any of the diabetic side effects, such as if our person has autonomic urinary retention because of the damaged nerve, they are going to have an increased chance of urinary retention. They're going to have this long procedure, they're going to come out of the procedure, and then they can't pee. Well, why can't you pee? It is because of their diabetes history. So we may have to do an intermittent catheter on them. Usually you do it a few times and the bladder will kick back into gear. They may experience either sudden tachycardia or sudden bradycardia. Our patients, because their vessels are not as responsive, are more prone to postural hypotension. So fall risk, who? That guy. Remember that gastroparesis? So patients are going to be very prone to nausea and reflux, having like heartburn. So oftentimes patients will get on anti-ulcer medications just while they're in the hospital, especially if they've had surgery. And last but not least, remember our gut is going to be a little bit slower, so we're going to be more gassy, and we are more likely to see cases of postoperative paralytic ileus. That means fancy for paralyzed small bowel. So we need to make sure to mitigate those problems by getting our patient up early if they can ambulate. That's how you're going to at least reduce the paralytic ileus. And move them slowly so they don't pass out with postural hypotension. We need to make sure to look at their drug list. All of you CRNAs out there, please pay attention, or future CRNAs. The two drugs I'm looking at are metformin and sulfonylureas. One of these, sulfonylurea, is called glipizide. We talked about that in the first diabetic lesson, I guess. And so we need to stop glipizide and metformin a day prior to their surgery. And we need to maybe consider resuming it when their kidneys are back normal. This is usually about 48 hours afterward. Usually the doctors take a double look at that and go for it. Well, what are you supposed to do with their sugar in the meantime? That's a good question. We are going to go ahead and give them insulin. We're going to give them insulin post-op. We call those insulin bridges. Yep. It's not really a physical bridge you walk over, just imagine. All right. Before patients go into surgery, we are going to test their sugar while they're NPO, and their sugar must be between 140 and 180. They must be between 140 and 180. Doctors will actually cancel surgeries if a patient's sugar is greater than that, because the mortality rates are increased by tremendous percent if you cut on a person who has a really high blood sugar. The outcome is not good. So they may delay the procedure for a few hours, get the person's sugar under control. So good communication to your CRNA if you are the floor nurse. And CRNAs, please ask, and if you see in your interview your person is a diabetic, ask them, what is your most recent sugar? And it needs to be not done like a day ago, within a few hours. Wonderful. During surgery, a patient does have the tendency to go either super high in their sugar or super low in their sugar. It can kind of go either or. So not the circulating nurse, but the CRNA is going to be doing frequent AccuChecks or blood sugar checks, and they may administer insulin. They may administer glucose, such as in a drip, dextrose 5% or LR or whatever, they may administer that, and they may administer potassium even during the surgery. It really just depends on the numbers, and this will be done on an hourly basis. We want to make sure our patient does not get hypothermic while they're on the table. Hypothermia can also lead to high blood glucose levels. So make sure we are checking that temperature and make sure we are checking that blood sugar. And of course, if they have an insulin pump, it better be off before they roll in surgery. Oh, that'd be so bad. Okay, I already mentioned the insulin bridge. If a patient is on beta blockers, we must know and recognize that our typical signs and symptoms of hypoglycemia are going to be masked. So let's make sure to actually do a capillary stick and rely on that rather than the patient's physical symptoms. If a post-op patient develops hyperglycemia, do know this is oftentimes going to follow just before a fever spikes, and if this happens, you better check your patient for infection. So hyperglycemia occurs before a fever. Double check your patient for infection. I'd be suspicious. Look for redness, swelling, tenderness, drainage, and high white blood cells, and tachycardia, and tachypnea. Oh my gosh, it just keeps going. Okay, hypokalemia occurs in a patient due to excessive insulin being given, either in surgery. You know what organ wants the potassium in a certain range. Which one is that? Lub-dub, lub-dub? Right, the heart. So it's not a bad idea to sometimes have your patient post-op to have an EKG on them, because we are looking for those hypokalemia episodes, and God forbid they have a silent MI in surgery. But I haven't seen the first procedure done where diabetic doesn't have an EKG already on them. Just know it's there. What else do I want to say about this? I think I want to hit on the one part about keeping the blood sugar between 140 and 180. Any of you ICU nurses out there, the ICU units have very specific protocols of where we do not want the blood sugar too high or too low, because we are going to have poor outcomes with our patient. So even though your patient may be a well-controlled diabetic, when they're on the when they're on the mend, while they're in ICU, make sure that their sugars are heavily regulated. Patients do not like being pricked, I'll tell you that. Too bad. And for the rest of the hospital population, if they're a non-critical patient, we prefer their sugar to be between 140 and 70. I said that backwards. 70 and 140. Right. All right. Peripheral neuropathy. Clean patient's feet with lukewarm water and mild soap. Nothing too strong, or it's going to begin to strip the skin of moisture and the good healthy bacteria. Not too hot water. Make sure the patient feels with their hand first before they put their feet into anything, because it can scald. Let's inspect their feet daily and make sure patients know how to inspect their feet. They are not allowed to walk around barefooted. That is a really bad idea. Or in shoes that they're not strapped onto the feet as well, like flip-flops. And that means no open-toed shoes. Also not a good idea. If they stub their feet, we want to damage the shoe and not their skin. Toenails should be trimmed properly. And what I mean by this is they are going to be cut straight across. And then we are going to make sure to trim the nails when they are soft, say like after a shower. Patients need to report non-healing wounds immediately. Not, oh, if I can't bandage it, it's, hey, I got something going on right now. Most amputations actually follow a foot ulcer, and the 5-year mortality rate after that is very high. After an amputation, meaning you get an amputation and within 5 years the chances of you still being alive are actually pretty slim. You're probably going to die. Most neuropathy damages the nerves of the foot muscles, and foot deformities develop. So as you see right here on the left, we're going to have something called Charcot's foot. It's spelled very interestingly. It looks like Charcot's, but we pronounce it as Charcot's, like a shark. So we also know this as the rocker bottom foot, and they need a special shoe for this because a lot of new pressure points develop that shoes cannot accommodate. And this would not be a good situation because it's going to wear a hole in their foot. What is the definition of Charcot's foot? This is where the hallux valgus turns inward of the great toe. So actually, there's a really good picture in your textbook of what the hallux valgus turning inward looks like. It is usually going to be warm and swollen, and this is actually very painful. Walking on that collapsed arch is very challenging. Their foot is actually going to be shortened, and a special boot is actually essential. The foot on the right is another deformity that occurs in our diabetic patients. They call this claw-toe deformity. Claw-toe deformity. This also occurs in people who wear heels a lot and wear shoes that are too tight. I know. About to go clean out your closet, aren't you? But in claw-toe deformity, the metatarsals heads are deformed, and the ball of the foot actually drops down and a callus is formed. This leads to ulceration and infection because it's very challenging to find a shoe that would fit that. All right, let's keep checking our skin because the skin down there is going to be very thin and there's going to be poor temperature regulation. So foot injuries, maybe from thermal injuries, like it's too cold outside, they're not going to recognize it, or maybe they're walking barefoot on hot ground, like hot pavement. They won't recognize that. And chemical burns can also occur from like over-the-counter treatments, maybe like plantar ulcers treatments. Excuse me, let me rephrase that. Plantar ulcers can develop from continuous pressure in a certain area, especially over the great toe or the tops of the claw toe. A little tip right there. Injury. Just asking for it. These patients do have poor gait and stepping mechanics. They're going to probably have some severe nail pathologies, so we'll need to probably consult a podiatrist for this. If your diabetic patient is a smoker, please urge them to stop to reduce vascular complications, because if they have poor vessels down there plus a wound, we are really increasing our chance to have an amputation. And we know what happens after 5 years, or before 5 years, after an amputation. They need to have a foot evaluation annually by a professional, and you can actually perform a monofilament test. A monofilament test is where you take a, to me it looks like a little wire, and you use enough force to bend the monofilament, and you test their feet in different area, and you are looking to see where do they have diabetic neuropathy and where they don't. Don't slide the filament across their skin. Ask them to close their eyes, and you just kind of like poke on the right side and you poke on the left side, poke on the right side, poke on the left, and you just go to the bilateral site. So if you're on the top of the foot on one, then you go to the top of the foot on the other, and you're going to document their response to the monofilament test. This is going to let us know if a person has a lot of numbness, that they do not have a protective sensation, and they are probably going to begin showing evidence of a foot deformity in about 3 to 6 months. Right, I know they're not going to have a protective sensation, so they're going to like trip on themselves, damage their toes. All of this should prompt us to recommend that they see a vascular doctor for maybe some procedures such as vessel revascularization, like putting a stent or something like that in there. When to shop for shoes. We're going to shop in the midday to the evening. I know I suggested 5 p.m. would be a great time. That's when your feet are the largest to go find some shoes. Socks. This is important. Socks. I said socks. Your socks should not have. Socks should not have thick seams, creases, or holes. New shoes may need a break-in period, so wear your new shoes for maybe a few hours and then switch them to some other ones. Ask a patient if they have a mirror to inspect their feet. They need to inspect it daily, and we need to offload. What do I mean by offload? We actually can encourage our patient to switch shoes midday, or take their shoes off, or get off their feet for an hour or so with their shoes off. I think that's a good idea for even myself, actually. By doing this, we are actually going to eliminate the pressure on any one area of the foot, and we're going to reduce the chance that they're going to get an infection. Goodness, because that infection could lead to necrosis, and just gets bad from there. Some options for shoes. You can have shoe inserts to distribute their weight. They can have something called half shoes, cast walkers, and it goes on up the scale. Wheelchairs, crutches. It is not uncommon for foot ulcers to last for years. I know, I just said that. They're going to last for years. I asked this one guy, how long have you had this one? And he was like, 2.5. Yep, it takes that long for it to go away. So foot ulcers will reoccur unless they permanently distribute their weight to a wider area of the foot. The last thing I want to cover, I know I've been talking forever, 8 minutes. Whew, okay. Pain management. Patients report in their, issues with peripheral neuropathy, burning, tingling, muscle cramps, and the pain is also described as darting and piercing. It's pretty bad. One medication that we like to give to them is gabapentin, also known as Neurontin. This is a medication that has lots of little indications for seizures, and we also give it for depression, but we are going to give it to this person for their peripheral neuropathy. Please do not operate heavy equipment when first placed on this medication. Blah, blah, blah. It makes you sleepy. That's why. Pregabalin is another medication to help with peripheral neuropathy. It has less sedative type of effects. However, it is a bit more expensive, and it's called pregabalin. We also know it as Lyrica. A patient can apply capsaicin 4 times per day to their skin. This is a topical analgesic, and it will help alleviate some of the burning, tingling pain. And while we are in the hospital to assist with pain, we can actually apply a bed cradle for hypersensitive skin. What a bed cradle is you actually prop up the sheet so it doesn't touch their toes or their feet. Okay, next we're going to talk about diabetic retinopathy. Diabetic retinopathy. Encourage our patient to go to the eye doctor, the ophthalmologist, every single year. Does it matter what type of diabetic you are? Meaning, do type 1s have to adhere to this, but not type 2s? Answer is no. Any type of diabetic should go to the eye doctor yearly. Encourage them to use light and contrast to help read labels or help read recipes, whatever they are reading. Family members can actually code the vials of insulin with markers, and they can color it. It's really important, especially if they are pulling up medication and they pull up the wrong one, like the long-acting for the short-acting or vice versa. It is not recommended for patients to have pre-filled syringes. They need to pull up their own dose, and that's to reduce medical errors. A magnifier is super helpful, as well as an audio glucometer. It actually reads it to you. For our patients who have diabetic nephropathy, which is basically a kidney failure due to high diabetes, let's make sure they are off NSAIDs. NSAIDs Some examples are ibuprofen, naproxen, and even, Celebrex, which is also known as celecoxib. That's a type of NSAID. Those are a no-go. We need to do an annual microalbumin check on somebody's urine. This is actually a very good and reliable indicator of somebody to develop kidney disease, or if somebody is developing kidney disease. It's an early indicator, yep, if somebody is developing kidney disease. Excuse me. So that's us right here checking their protein levels, the microalbuminuria, checking for that. Let's look at their I's and O's. Is enough coming in and enough coming out, or is our patient gaining weight? I want to make sure everything is coming out. Let's make sure their BUN and creatinine are within normal limits, because if not, I may hold back on some of my anti-diabetic medications, or I may even have to reduce a dose, because a little bit will go a long way in somebody who has a elevated BUN and creatinine. We are going to give ACE inhibitors and ARBs. Now, if somebody is progressing in their diabetic nephropathy, we actually have to come off the ACEs and the ARBs. However, it is very helpful for a patient, and it offers a little bit of protective effects in preventing nephropathy. I know, how is it good early but not later? Just go with it. One of the reasons we don't want to give, or one of the reasons we have to monitor an ACE inhibitor is this little electrolyte likes to go up. Can you remember which one it is? A little electrolyte that rises, yes, hyperkalemia. So please monitor your patient's potassium if they're on an ACE or an ARB. Excuse me. Some other nephrotoxic agents that I'm thinking of are antibiotics. We will learn a little bit more about nephrotoxic antibiotics later, but for now, we'll just be good with this generalization here. And make sure our patients, if they have diabetic nephropathy, are on a low protein diet. I know, a low protein diet can actually slow the progression of a person's nephropathy. They will be good for longer. Protein's really hard on the kidneys. Yes. Here's a simple question. What do you think causes hypoglycemia? Too much insulin? Well, you're right, actually. Let's look at some other reasons of why somebody can develop hypoglycemia. All right. Here's one of your reasons. Too much insulin, right? If we were to accidentally administer a higher dose, maybe we looked at the wrong sliding scale, we could very well give somebody an inappropriate dose of insulin for their sugar. We could administer it too early. Occasionally at some hospitals that I have worked at, the techs will check the patient's sugar at like 9 or 10, and then the lunch trays come at 12 or 1. We need to make sure to check somebody's sugar within 1 hour of their meal, and we need to give the insulin about 10 minutes just before their meal comes. I know that's a lot of coordinating, but we have this one person in the hospital that his blood sugar was tested around 10:45 and it was 2:30. The student and I went and were trying to get everything done to get him his insulin, and here it was 12 o'clock. We are definitely outside our 1 hour range, and I told the student it's really not good for us to give the insulin based on a sugar that's that old because it could change. Let's go ahead and poke him again and just apologize. Yep, it's called humble pie, y'all. Tastes like lemons. So we went in there, told him that we, dragged our feet. We're not able to get in there in time. And he let us check his sugar, and I'll be darned if it didn't come down to 100. And according to the sliding scale, we actually owed him 0 units, where before we were going to give him 8. Super glad we timed that out right. So give the shots within 10 minutes of the meal and make sure the sugar is not an hour old. Wrong type of insulin. That one's pretty obvious. Decreased food intake. Somebody may have felt that they were going to eat 45 grams of carbohydrates, but then they felt full at half of that. So oftentimes they'll have to eat a little snack when they're starting to, when that feeling of fullness goes away. They budgeted out 45 grams. Our patients are going to have delayed gastric emptying, or that gastroparesis. This is very challenging because they'll ingest the food, but it doesn't move through their gut like we need it to. So oftentimes patients will be on medications to help move food through them, such as metoclopramide, or it's also known as Reglan. You don't need to memorize that for the test. I'm just letting you know we give medications for this reason. Another reason for hypoglycemia, oh, look at there, alcohol consumption. Yep, eat a small meal before and you'll be all right. Make sure to consume alcohol in moderation. This one right here I find is fascinating. We had a gentleman in the hospital who was scheduled to get 6 units of insulin because his sugar, I think, was 270. Yeah, he was supposed to get 6 units, and so we go on in there and he says, I cannot take 6 units or I'm gonna bottom out. And I said, well, you know, did the doctor go over your med list with you? And he said, yeah, but I do my own thing. I was like, well, what do you mean? And he said, I used to take 6 units for this sugar. However, now that I've lost 100 pounds, I think he had cancer or something, but now that I've lost 100 pounds, for that blood sugar, I only need like 3 units because it's going to go a long way for me. And you know what? At that point, I said, did you let the nurses know about this weight change and how the order is actually sort of outdated? And he said, no, I just do my own thing. Yeah, so that's not safe. So we actually reported it back to the nurse, the patient's findings and what he said, and we called the doctor, and the doctor agreed to lessen the pre-ordered dose of insulin, and we were going to see how the patient responded to that. I'm telling you, insulin's dangerous. And if that patient didn't stop us, you know, that would have been bad. I mean, the doctor ordered it, right? But he had a huge weight loss. All right, so what are we going to do if your person has hypoglycemia? There is a lovely chapter that sort of details all of the different stages of hypoglycemia, and there is such a thing as hypoglycemic unawareness, where a person's sugar is dropping, but they're not even conscious of it. This could be the person maybe is a long-standing diabetic, or they're just not in tune with their body, but whatever it is, the most reliable thing for us is checking a person's sugar. Now that, I'm going to say, is going to be flipped the other way. I've actually had patients, my older adults, and even my long-standing diabetics who are like 45 years old, they will have a normal blood sugar, say at like 70 or 75, but they will actually show signs and symptoms of hypoglycemia. That's because they have, maybe their body has been changed to live at a higher blood sugar level, so they will be symptomatic earlier. In those situations, if my person is symptomatic but they're not low, according to the textbook, I will actually treat them according to their symptoms. Okay? You may have to listen to that one again. So what are we going to do? If a person's blood sugar is less than 60 and they're still conscious, they are hungry, they're irritable, maybe they report a headache, we like to say that they are hangry, and you want to go ahead and treat them with 15 grams of carbohydrate, maybe a couple of tablets of glucose, maybe a granola bar or orange juice. A lot of times I will give them orange juice and put a packet of sugar or 2, and please make sure to follow it with a protein such as either milk or peanut butter. That would also be good. If somebody has moderate low blood sugar, that's between roughly, could be 60, between 60 and 40, really kind of just depends on their symptoms. We're going to see them if they're cold. I mixed cool and cold. I got cooled. If they're cold and cool, clammy and pale, and they have tachycardia, a rapid pulse, and if they have shallow respirations, and they have changes in mood, and if they're drowsy even, we're going to consider it moderate and proceed to give them extra sugar to try to get them to bring their sugar back up. You're going to give them about 15 to 20 grams of carbohydrates. And after any intervention, what do? If we follow the 80-PI policy, we're going to assess. We see that they're cool and clammy and pale and having weird behavior. We're going to diagnose them as having hypoglycemia. We're going to plan. I'm going to give you this much. We're going to do our intervention. And then what's the E? Students forget the E all the time. We're going to evaluate. So what's the normal time to evaluate somebody after we give them all these crackers and such? About 15 minutes. You're going to probably stay with that patient. You're going to give it to them and then recheck their sugar in 15 minutes. What if it didn't change? You're going to do everything all over again. Usually after the third attempt to get their sugar back up, if it is not coming back up, I would probably notify the doctor. They may put them on dextrose 5%, move them to the ICU or progressive care unit. It's very odd after 3 attempts if somebody doesn't bring their sugar back up. Okay. All right. The next category of hypoglycemia is severe. This is where their sugar is less than 40 and they are unable to swallow. They're unconscious. They may even have a seizure on you. They're way past the cold, clammy part. They look kind of like death, actually. That's not good. At this point, you are going to want to give somebody glucagon. That is an IM injection, 1 milligram into their thigh or into their deltoid. And you're going to recheck them in 15 minutes. If they have an IV access, and I would probably choose to do the quicker route, which would be IV glucose. Now, the IV is actually 50% glucose, and please know if you've ever tried to push, some of my students are EMTs, pushing, well, EMTs, sorry, they're paramedics because they push meds. Oh my goodness, have you ever pushed syrup through a teeny tiny little hole? It is very challenging. Your hands end up shaking because you're pushing this solution so hard and it's so thick and viscous. It's like it doesn't even want to move. So I pre-warn you now, so whenever you do it, you don't look like, if everybody's hands shake as they're trying to push it because it's very thick. But also I want to say, I made a note to myself to repeat glucagon in 10 minutes. Okay, we'll do 10 minutes. It is really important for our patients to wear a MedAlert bracelet. I think our gentleman who was yelling sugar would have been in a much better situation had he maybe had some kind of identification that he had a blood sugar issue. Right, we could do a failure to rescue. That's not good. Finally, questions. All right, I'm going to pause this. You go ahead and read it. Please pause. All right, at this point you have probably unpaused it, and here are your answers. Boop. Right. Metabolic syndrome is the simultaneous presence of metabolic factors known to increase the risk for developing type 2 diabetes and cardiovascular disease. And as you see the features there, official features, waist circumference 40 inches or more for men and 35 inches or more for females. The fasting sugar is usually more elevated than that. That's why that's not an option. Well, you don't need me to read this to you. Okay, there you go. Please pause this. Okay, at this point, I'm going to go ahead and reveal the answer. Confusion. Glucose is super necessary for brain function, and confusion is a marker of severe hypoglycemia. And I just want to let you know that your patients, when they go hypoglycemic and their behavior starts to change, they're not cooperative at all. I probably need to warn you that you're going to have some very bizarre, abnormal behavior. And when you ask them, sir, I think your sugar is low, let me go ahead and test you, he's not going to be like, oh, sure, that sounds great. Or can you please drink this juice? It's going to look like something from Steel Magnolias with Julia, oh, what's her name? Yep, can't think of it. But she's fighting the ladies in the salon who are trying to get her to drink sugar. You're going to probably need some backup if somebody's at that level, because they are not compliant at all. And they might even become aggressive if they have, yeah, totally out of character if they go hypoglycemic and they're still conscious. Whew. Okay, please pause. Okay, I'm going to go ahead and reveal the answer. Doo-doo. Please be sure when you read these, the nurse understands what should the patient avoid. Avoid is the key here. All right. I have no idea what video this is from. I have built an assessment tool to see if you are now capable to safely administer medications to my virtual diabetic patient. Can you read labels? I don't know. Can you? Can you administer the right dose? I don't know. Can you? Prove yourself worthy of being my heir. I challenge you to go to the diabetic module now and take the survey. Or quiz, whatever you want to call it. Okay, this slide means there is nothing left on my to-do teach list, so go now, read your med-surg text, and take the challenge.